dim this light a little bit as well. Yeah, just bring that down. Okay. Big. Dad, you going to bring it down a bit? Yeah. Right, I'd like to welcome everybody and thank you for taking the time out of your schedule to come to the presentation this evening. And my name's Dr. Richard Kaul, and I'm one of the physicians with New Jersey Spine and Rehabilitation. And what I'm going to be talking about today, or this evening, is one, the emerging field of minimally invasive spine. And I'm going to be talking about some of the sort of background principles to spine care, the evolution of minimally invasive spine, and really how, with regards to the way we treat patients with back problems, it's going to become the standard of care, in the very near future. So I'm going to just kind of start off and go through some sort of general background stuff. And spine care today, it's becoming much more essential that a multidisciplinary approach to the spine patient becomes a part of how we interact. So between physical therapists, chiropractors, orthopedic spine surgeons, interventional pain physicians, there has to be, or there is an increasing collaboration to provide more optimal care. And with spine care today, and with the minimally invasive evolution, there's an increasing use of fluoroscopy, image guidance, and percutaneous techniques. And as we evolve and we move into these new areas and these new techniques, the utilization of evidence-based medicine assumes increasing importance so that we can demonstrate that what we're doing with these new technologies actually works. So, the tried and trusted principles of a good history, a good physical examination, and the utilization of appropriate diagnostic modalities still applies. I mean, that's the same. That's not going to change. And, in a spine practice, we routinely use plain X-rays, CTs, nerve conduction tests, discography, and selective nerve blockades for the purposes of pain mapping. The spectrum of conditions that are amenable to the minimally invasive or the percutaneous approach really commenced with just degenerative conditions of the spine. And as the technology has evolved, it's now including both traumatic and tumor and deformities. So deformities are now being increasingly addressed with MIS approaches. So the treatment options that are utilized are really kind of on a spectrum, and people with back pain, with spinal conditions, will start off with physical therapy, chiropractic care, spinal decompression, non-steroidals, occasionally mild opiates, and they will work their way through an increasingly, an escalating level of care. And with a small percentage of patients ultimately requiring fusion, which can now be carried out in a much less invasive fashion. So the surgical options that exist really are pretty limited. I mean, we can either decompress the spine, confuse it, we can stabilize it, or we can use motion-preserving devices. And I'll talk a little bit about these later on. And these essentially provide another step on the treatment algorithm. So, I'm sure all of you guys are familiar with, these types of incisions and this type of approach. And, this is the way that back surgery, has been carried out for many decades. And it kind of demonstrates really a disregard for the all of the posterior stabilizing elements of the back. And, you can see that to get down to where the problem exists, one used to have to dissect through and destroy a lot of these posterior stabilizing elements. And this was one of the main factors that underpinned the increased incidence of nosocomial or hospital-based infections in spine surgical patients. So, what are the advantages of, the minimally invasive approach? Well, it's significantly less blood loss, which means that, again, we don't have to keep patients in hospital. It means that there's a much lower incidence of a post-op infection and morbidity. We have a quicker return to function. Patients now don't need to take 3 to 6 months off and 3 to 6 months of rehabilitation after they've had a fusion. Because we've preserved all of those posterior elements, we're now able to get them back into the workplace in a much shorter space of time. There are lower medication requirements. The routine use of post-operative opiates to control patients' pains, they had their own complications, with urinary retention, constipation. And what's being seen increasingly is that these procedures can be carried out on a same-day basis, which is a great thing from many perspectives, one being cost. So I'm just going to go through some of the different techniques and some of the different instruments that we use to carry out minimally invasive or percutaneous spine surgery. And the endoscope it's kind of like it's one of the main instruments or one of the main tools that we use. And the principles of this particular device are the same principles that are used for knee and shoulder surgery. We have a rigid device that has a working channel, a channel for the video optic fiber, and an irrigation channel. And in the bottom right-hand corner of the slide, this is kind of a rough idea of what one would see when the endoscope is placed into the disc. The anatomical considerations that need to be looked at when approaching the disc in a posterolateral fashion relate to the identification of what we refer to as Cambin's triangle. And we have the exiting nerve root here, the traversing nerve root here, and in between these two we have the point of entry into the disc. Okay, I'm going to flip over to I'm going to use a video file to demonstrate the endoscopic technique. Now hopefully you can see this okay. Is that okay? You guys can... Danny, do you want to turn off that light? Okay, so this is a video file. I'm just going to slow that down. This is a video clip of an endoscopic lumbar decompression, and obviously, as you can see, fluoroscopic guidance is really critical to this procedure. So we start off with the insertion of a needle through the posterolateral margin of the disc. I don't know if you can see on the X-ray. We inject some contrast into the disc space for identification and for the purposes of discography. This is a sheath that's inserted through the back of the disc, and it's advanced under fluoroscopic guidance into the disc space. And you can see it's like a 2 or 3 millimeter incision, and this is the view down the scope. The blue it's indigo carmine, and it stains the degenerated material within the disc space. So by using the stain, when we go down, we can see what needs to be removed. So we use a combination of instruments to decompress the disc. We use some microforceps, some micropituitaries. And this is a radiofrequency probe, which causes a thermoablation of the degenerated material and allows thermoablation of annular fibers as well. And the degeneration of the annular fibers are one of the main contributors to patients' back pain. So you can see that the sheath has been pulled out. Up here we have the spinal canal, and this is the junction between the posterior margin of the disc space and the spinal canal, which is up here at 12 o'clock. And this is the area of the disc where pathology really occurs. So the work, the decompression will tend to focus on this particular part of the disc, which is a more selective way of treating the disc than just going in and manually decompressing things centrally. So this is a little bit of epidural fat. And the disc has been decompressed internally and at this key element. And this is